everyone. Welcome back to PodBites, where we break down complex medical topics into bite sized pieces, perfect for your commute, coffee break, or whenever curiosity calls. I'm Reem Ahmed, your host for today, back again from the renal episode, and you know me, I like my organs when they come in pairs. And today, I'm joined by Areeba, where we'll be jumping into something that can be a little twisted, quite literally ovarian cysts and tumors.
They're twisted indeed. There's a lot going on in those little pelvic powerhouses, from benign functional cysts to scary surface epithelial carcinomas. We're about to unpack it all.
Okay, before we dive into all the juicy details, let's give our listeners a quick roadmap. Ariba, what are we covering today?
Glad you asked. Today's episode is all about ovarian cysts and tumors. First, we'll start simple with functional cysts like follicular and luteal cysts. Then we'll get into the hormonal chaos of polycystic ovary syndrome or PCOS.
After that, we shift gears into the big players, ovarian tumors, and we're breaking them down by origin, right?
Exactly. We'll explore tumors from the surface epithelium like serous, mucinous, and endometrioid types, then dive into germ cell tumors like teratomas, dysgerminomas, and yolk sac tumors. After that, we'll cover sex cord-stromal tumors, including Granulosa-cell tumors and Sertoli-Leydig tumors.
And we're definitely not forgetting the sneaky ones, metastatic tumors like Krukenberg.
Yeah. Plus, we've got some cases and practice questions, and of course, some interesting puns along the way.
All right, Ariba, can you walk us through how the ovary is even organized before we start dissecting all these tumors?
Absolutely, Reem. If we zoom in on the ovary under a microscope, we'll see it's made up of three main compartments, each with the potential to give rise to a different type of tumor.
Three compartments? Let's break them down.
First up is the surface epithelium, which actually comes from the Mullerian ducts during development. Most ovarian tumors arise from here, like serous and mucinous tumors.
Right, and that's why we call them surface epithelial tumors. What's next?
Then we have the germ cells. These are the cells that give rise to the oocytes. When they go rogue, they can form tumors like teratomas, dysgerminomas, and yolk sac tumors.
Okay, so oocyte markers gone wild. Got it. What's the third category?
The third and the final group is the sex cord-stromal cells. These include the granulosa and the theca cells, which are responsible for hormone production. Tumors from this group include granulosa cell tumors and Sertoli-Leydig cell tumors.
So to recap, the ovary is like a little three-layer cake of tumor potential. Surface epithelium, germ cells, and hormone-producing stromal cells.
Exactly. And let's not forget the bonus category, metastatic tumors. These don't originate in the ovary at all, but they show up there, like uninvited guests. Think Krukenberg tumors from the GI tract or mucinous metastasis from the appendix.
Perfect. That makes classification so much easier. Now that we've got the anatomy and origins down, let's kick things off with the simplest lesions, functional ovarian cysts.
Okay, functional cysts are non-neoplastic and just part of the normal cycle. They usually come and go without anyone even noticing.
Let's begin with the follicular cysts. These are the most common, aren't they?
They are. Here's the deal. Every month, follicles develop as part of ovulation prep. But if a follicle doesn't rupture, or if it does and then fails to regress, it can enlarge and form a follicular cyst.
Right, and the size matters here. If it's under 2 centimeters, we just call it a cystic follicle. If it's over 2 centimeters, that's when it earns the name follicular cyst.
You're right. These usually have clear serous fluid, and histologically, you might see a thin wall lined by granulosa cells. When the pressure's low, those cells are still visible, but with high pressure, they can flatten out or even disappear.
Clinically, they can cause mild mid-cycle pelvic pain, but many are asymptomatic and just found incidentally in ultrasound.
Yeah, and then typically resolve on their own within a few cycles. No treatment needed unless they persist or cause symptoms.
All right, moving on. What about luteal cysts?
These come from the corpus luteum, which forms after ovulation. Normally, if there's no pregnancy, the corpus luteum regresses. But if it sticks around and starts accumulating fluid or even hemorrhages, it becomes a luteal cyst.
And on gross exam, it's got that classic bright yellow wall because of the luteinized granulosa cells.
Exactly. If it hemorrhages, it can cause acute pain or even rupture, leading to hemoperitoneum. But again, Like follicular cysts, most of them resolve spontaneously.
So both follicular and luteal cysts are functional, common, and usually harmless, but can occasionally mimic more serious conditions like ectopic pregnancy or ovarian torsion.
Yep, and that's why clinical context and imaging are key.
All right, quiz time. What's the histological hallmark of a follicular cyst, especially when the pressure is low?
The answer is granulosa lining cells. Low pressure means the wall doesn't get destroyed, so you can still see them.
All right, let's level up from single cysts to something a little more complex. Areeba, I want you to picture this. A 24-year-old woman comes to the clinic complaining of irregular periods. She also noticed weight gain, increased facial hair, and some stubborn acne. Her ultrasound shows bilaterally enlarged ovaries with multiple small peripheral cysts.
That sounds like the classic string of pearls appearance. We're definitely dealing with polycystic ovary syndrome, or PCOS.
Exactly. And I feel like everyone hears about PCOS, but not everyone gets what actually goes on under the surface. Can you walk us through it?
Sure. It all starts with increased LH secretion that stimulates the theca internal cells in the ovary to crank out androgens.
Ah, so too much LH means too much androgens.
Exactly. And those excess androgens throw everything off. They prevent normal follicular maturation. So instead of one dominant follicle ovulating, you get a bunch of immature follicles just hanging around.
And that's what we see on ultrasound, the multiple tiny cysts at the periphery, right?
Yep, that string of pearls look. And to make matters worse, there's often insulin resistance, which further boosts androgen production.
Wow, so it's like a hormonal domino effect. More androgens equals less ovulation equals irregular periods. And throw in acne and hirsutism while you're at it.
Right? So, clinically, you see oligomenorrhea, anovulation, obesity, hirsutism, and sometimes even virilization.
And what about the ovaries themselves? What do they look like?
Great question. Grossly, they're enlarged, gray white, and the cortex is thickened and fibrotic. Histologically, you'll see follicular hypothecosis, a thickened fibrotic cortex, and notably, no corpora lutea.
No corpora lutea because there's no ovulation.
Bingo! And that's a key feature. It confirms that the ovary isn't going through its normal cycle.
And this isn't just about cycles. PCOS has broader implications too, like infertility, an increased risk of endometrial hyperplasia, or even carcinoma, right?
Absolutely. All that unopposed estrogen from chronic anovulation can thicken the endometrium over time.
So, to sum it up, PCOS is a hormonal imbalance driven by excess LH and insulin resistance, leading to androgen excess and ovulation and all those clinical features.
Yep, and it's super common. So, definitely a must know for exams and real life clinical practice.
All right, quiz time. Here we go. A 23-year-old woman presents with oligomenorrhea, hirsutism, and acne. Ultrasound shows bilaterally enlarged ovaries with multiple peripheral cysts. Which of the following is the primary hormonal abnormality driving her condition? A. Decreased FSH. B. Increased estrogen. C. Increased insulin sensitivity. D. Increased LH secretion. Or E. Decreased androgens.
The answer is D. Increased LH secretion.
Nice, and that excess LH stimulates the theca cells to pump out androgens, which disrupts follicle maturation, causes anovulation, and leads to the full PCOS picture. Okay, now on to the heavy hitters, the epithelial tumors. We've got serous, mucinous, endometrioid, clear cell, Brenner, and cystadenofibroma, right?
Yep, these are the most common type of ovarian tumors, and they all come from the Mullerian epithelium. Imagine a 40-year-old woman with abdominal fullness and early satiety. CT shows bilateral ovarian masses filled with clear fluid.
Clear fluid. So it's probably a serous tumor, aka the most common ovarian tumor.
Exactly. These are cystic tumors lined by ciliated columnar epithelium and filled with serous fluid, and we can classify them based on degree of malignancy. So a benign tumor usually occurs in women aged 20 to 45 years. A malignant tumor has nuclear atypia, samoma bodies, and stromal infiltration. A borderline tumor is somewhere in between. It has more complexity, but no stromal invasion.
Wait, Samoma bodies in the malignant one? Those are the little calcified swirlies, right?
Yeah, We see them in a papillary serous carcinoma. Oh, and don't forget the BRCA1 and 2 and P53 associations in high-grade carcinomas. Malignant serous tumors often have P53 mutations, especially if high-grade. Low-grade tumors, though, tend to have KRAS or BRAF mutations.
Are there any other features of malignant serous tumors we should know about?
Yes, malignant serous carcinoma have many risk factors like nulliparity, family history, genetic mutations. You better remember them because I'm going to ask about it later. Gonadal dysgenesis in childhood, which carries higher risk, and women in their 40s to late 50s on OCP or with tubal ligations, but this carries lower risk. Also, these tumors are often bilateral and may cause ascites if they spread to the peritoneum. One tumor marker is CA125, which may be elevated, but it is not specific.
What about the prognosis?
If it's confined to the ovary, prognosis is excellent, and borderline tumors have nearly 100% survival. But once it spreads to the peritoneum, prognosis drops. In fact, malignant tumors have only 25% survival if peritoneal spread occurs.
All right, PodBiters. Here's a question to test yourself. What's the mutation difference between low-grade and high-grade serous tumors?
The answer is, in low-grade tumors, we have KRAS or BRAF mutations, but in a high-grade tumor, we have P53 mutations, especially in BRCA1 and 2 carriers. Next up is a 45-year-old woman who presents with progressive abdominal distension. Imaging shows a huge unilateral multiloculated cystic mass, over 25 kilograms, and the fluid is thick and gelatinous.
Ooh, that sounds heavy and mucinous.
That's it. Mucinous tumors are filled with mucin-rich glycoproteins, and they form massive multiloculated cysts. Most are benign or borderline. Only 15% are malignant.
And I know these tumors are usually unilateral, and if you see bilateral mucinous tumors, you should always rule out metastasis, like from the GI tract. They're also often linked to KRAS mutations and even smoking as a risk factor. But how can we classify them based on morphology?
So, benign mucinous cyst adenomas have tall columnar epithelium with apical mucin. Then the borderline tumors show epithelial proliferation and mild atypia. And finally, malignant ones have loss of architecture, necrosis, and difficulty identifying stromal invasion, unlike serous tumors.
How big do they get?
These can get so big that patients might come in looking pregnant. They're filled with gelatinous mucin and the walls are multiloculated, meaning they have multiple little compartments.
When we look at the prognosis of mucinous tumors, benign and borderline types have excellent prognosis. Malignant types can sometimes be treated as well, but only if it's confined to the ovary. But if it spreads beyond, it's often fatal, especially if it causes pseudomyxoma peritonei.
Yes, the jelly belly thing.
Yep, that's when mucin from a ruptured tumor spreads throughout the peritoneum, often from a mucinous appendiceal tumor, not ovarian originally. All right, let's take a practice question. A mucinous ovarian tumor is bilateral. What's your next best step?
Rule out extra ovarian origin, like a metastasis from the GI tract.
All right, shifting gears to the surface epithelial tumors, time to tackle one that sounds like it belongs in the uterus but actually shows up in the ovary. Here's the case. We've got a 60-year-old postmenopausal woman presenting with vaginal bleeding. Imaging reveals a cystic ovarian mass with some solid components. Her endometrial stripe looks thickened too.
Oof, postmenopausal bleeding with endometrial thickening, and now an ovarian mass? I'm thinking endometrioid tumor.
Exactly. These are epithelial tumors that look a lot like endometrial glands. And fun fact, they often coexist with endometrial carcinoma.
Yeah, and that's why anytime you see an endometrioid tumor in the ovary, always assess the uterus too. It might be a dual hit.
And in terms of risk factors or associations, what's cooking at the genetic level?
Several mutations may be involved here. The big one is PTEN, a classic tumor suppressor gene that goes rogue. Then you've also got KRAS and beta-catenin mutations, and sometimes P53 if the tumor is high grade.
And morphologically, what are we looking at?
Histologically, you'll see tubular glands that look just like the endometrium. It's honestly pretty elegant. Grossly, the tumor might be solid or cystic, and it often appears yellow-tan with areas of necrosis or hemorrhage.
And these are usually malignant, right?
Correct. They tend to be malignant more often than not. But here's the good news. If it's stage 1, the 5-year survival is around 75%. Once it spreads, especially if it's bilateral, the prognosis worsens.
Bilateral involvement often means extra ovarian spread. Good to remember. All right, Areeba, are you ready for a quick quiz?
Let's go for it.
Which genetic mutation is most strongly associated with malignant endometrioid ovarian tumors?
That one's easy if you've been paying attention. The answer is P10, which is the most common culprit. Though KRAS and beta-catenin also play a role, P10 is the headliner here.
Perfect. Endometrioid tumors may sound like uterine business, but they definitely know how to make themselves at home in the ovary too.
Okay, Reem, ready for a case? A 48-year-old woman with a long-standing history of endometriosis comes in for a routine pelvic scan. They find a unilateral ovarian mass, and the biopsy shows large epithelial cells with clear cytoplasm arranged in tubules and solid sheets.
Oof. Endometriosis plus clear looking cells? That sounds like clear cell adenocarcinoma.
Bingo! It's one of the more aggressive surface epithelial tumors, and it's strongly associated with endometriosis.
Interesting. So, endometriosis isn't always benign. How exactly does it tie into this tumor?
Well, in some chronic cases, endometriotic tissue can undergo malignant transformation, and clear cell carcinoma is one of the classic outcomes. It can also be associated with endometrioid carcinoma, by the way.
Got it. Now, about the clear cells. Why do they look that way?
Good question. The clear cytoplasm is due to glycogen. It gets washed out during the slide prep, leaving the glassy appearance. And if you're looking under the scope, you might also see hobnail cells, which are pretty characteristic.
Oh, I remember those. Hobnail cells are the ones with the nuclei bulging out into the gland lumen, right? Kind of like little suction cups.
Exactly. Very weird looking, but very helpful diagnostically.
Okay, let's talk gross pathology. What do these tumors actually look like in the OR?
They're usually unilateral and they can be either solid or cystic. On gross exam, they often appear yellow tan and may have areas of hemorrhage or necrosis. Definitely not subtle.
And what about prognosis? Are they treatable?
Unfortunately, they're known to be chemoresistant and they often present at advanced stages. So, yeah, the prognosis tends to be worse than for serous or endometrioid tumors. Okay, Reem, here's a quick one for you. A 55-year-old woman comes in for a routine pelvic scan. She has no symptoms, but imaging reveals a solid unilateral ovarian mass. Histology shows nest of transitional epithelial cells. You know, like the ones lining the bladder.
Wait, transitional epithelium in the ovary? That has to be a Brenner tumor, right?
You're right. Brenner tumors are one of those weird but benign ovarian tumors made of urothelial-like epithelium.
That's actually so cool. So the cells look like bladder cells, but they're hanging out in the ovary?
Yeah, and that's why it's sometimes described as a bladder-like tumor of the ovary. Grossly, it's usually a solid, firm, unilateral mass, and it's often found incidentally.
And it's benign most of the time, right?
Exactly. Malignant Brenner tumors are super rare. Most are benign adenofibromas composed of fibrous stroma and those distinctive nests of transitional epithelial cells.
Okay, I remember this one as the bladder impersonator. What's next in our lightning round?
Next up, we have cyst adenofibroma. It's another benign surface epithelial tumor, but this one's a bit of a mix.
A mix how? Like cystic and solid?
You got it. It's composed of fibrous stroma, like an adenofibroma, but also has cystic components lined by columnar epithelium. You can think of it as a hybrid between a fibroma and a cyst adenoma.
So, does it look different on imaging compared to something like a serous cystadenoma?
Yep. So it might look multiloculated or complex due to the fibrous and cystic elements, but usually it's benign and unilateral, just like Brenner tumors.
And what about borderline or malignant potential?
Good question. So most are benign, but borderline and malignant forms do exist. They're just much rarer. In those cases, you'd look for atypia and invasion on histology.
Okay, so Brenner and cyst adenofibroma are like the chill, benign members of the surface epithelial squad, but we still have to keep an eye on them for rare upgrades.
Exactly. And because they're rare, they often show up as surprise findings during surgery or imaging for something else.
Love it. I feel like these two don't get enough attention, but now they're officially on our radar. Okay, what do you want to do next, Areeba?
Let's go for a quiz time.
Oh, I actually got a question for you. Which of the following histologic features is characteristic of a Brenner tumor? A. Hobnail cells lining clear spaces. B. Nests of transitional epithelium in the fibrous stroma. C. Cal-Exner bodies surrounded by cuboidal cells. D. Immature neuroepithelium. Or E. Cystic spaces lined by mucin secreting epithelium.
And the answer is B. Nests of transitional epithelium in fibrous stroma. Classic Brenner tumor histology. Looks like bladder tissue, but in the ovary.
Exactly. And remember, it's usually benign and found incidentally. Okay, Areeba, we've covered the major players from the surface epithelial group, but now it's time to shift gears. So we're finally talking about the germ cell tumors. I know these are more common in younger patients, right?
Yes, so germ cell tumors are the second most common ovarian tumors and the most common in young women, typically under 30. They mimic fetal and embryonic tissues, so the histology is, well, wild.
And first up, one of the most well-known and weirdest ones out there is the teratoma.
Okay, Reem, here it is to start with. A 25-year-old woman goes in for a routine pelvic ultrasound. She's asymptomatic, but the scan shows a well-circumscribed unilateral ovarian mass containing, you guessed it, hair, teeth, and sebaceous goo.
Okay, no symptoms but full-on dental chaos. This has to be a mature teratoma, aka dermoid cyst.
You're right. So a mature teratoma is a benign germ cell tumor made of well-differentiated tissues from 2 or 3 germ layers, ectoderm, mesoderm, and endoderm.
So it's basically a tumor made up of tissues from all over the body?
Yep, and that's why you can find all kinds of wild stuff in it, like skin, neural tissues, hair follicles, and even cartilage or bone.
And these are most common in young women, right?
Spot on. Typically seen in women under 30, and they're often found incidentally. They're usually unilateral and grossly filled with greasy, sebaceous material and sometimes teeth or bone.
What about histology? What do we see under the microscope?
That depends on what tissues are present, but you'll see mature, well organized structures like skin with adnexal elements, respiratory epithelium, or neural tissue.
All right, that's the benign one. But what if it turns malignant?
Then we're dealing with an immature teratoma, and that's a totally different story. These contain embryonic or fetal tissue, especially immature neuroepithelium, which is the key to grading the tumor.
So, more neuroepithelium, which means higher grade, which means more aggressive?
Exactly. And though they're malignant, if the tumor is confined to the ovary, the prognosis can still be good, especially with chemo.
Got it. And there's also the monodermal category, right? Like when the teratoma is made up of mostly one tissue type.
Yes, so two classic examples are struma ovarii, made mostly of thyroid tissue and can even cause hyperthyroidism. Then we have ovarian carcinoid. This is made up of intestinal type epithelium and may produce serotonin, causing carcinoid syndrome.
So basically, the ovary decides to become a mini thyroid or intestine? Don't love that.
Medicine is wild, Dream.
Okay, another question. Which histologic feature is most important when grading immature teratomas? A. Amount of sebaceous material. B. Presence of skin adnexal structures. C. Quantity of immature neuroepithelium. D. Number of germ layers. Or E. Presence of thyroid follicles.
And the answer for this one is C. Quantity of immature neuroepithelium. That's your key marker for grading and predicting behavior.
Perfect. And now we've got teeth, hair, and rogue thyroids. This tumor category definitely wins most bizarre.
All right, Reem. Next germ cell tumor coming your way. A 22-year-old woman with primary amenorrhea presents with lower abdominal pain. Imaging reveals a solid unilateral ovarian mass. On histology, the tumor is made up of large cells with clear cytoplasm and central nuclei, separated by fibrous septa with lymphocytes.
Ooh, this is ringing all the bells for dysgerminoma, right?
You got it. This germinoma is the most common malignant germ cell tumor of the ovary, and it's basically the female counterpart of seminoma in males.
Right. And you mentioned primary amenorrhea. Is that because of underlying gonadal dysgenesis?
Exactly. So, dysgerminomas can be associated with gonadal dysgenesis, like in Turner syndrome or androgen insensitivity. But even in otherwise healthy women, it tends to show up in their teens or 20s.
What makes it stand out histologically?
The key is those large uniform cells with clear cytoplasm and central nuclei, often described as fried egg appearance. Plus, the tumor has fibrous septa packed with lymphocytes, and sometimes even granulomas.
And we can use markers to help ID it too, right?
Yep, LDH is the most common serum marker, and some may also express HCG or c-KIT.
All right, let's talk treatment because this one, although malignant, has a good prognosis, right?
Absolutely. This germinoma is highly radiosensitive and chemoresponsive, and since it's usually unilateral, fertility sparing surgery is often an option. Prognosis is excellent, especially when caught early.
All right, Areeba, do you want to test the listener's memory?
Let's go for it.
Which of the following findings is most characteristic of a dysgerminoma on histology? A. Schiller-Duval bodies. B. Immature neuroepithelium. C. Large clear cells with fibrous septa and lymphocytes. Or D. Call-Exner bodies.
And the answer for this one is C. Large clear cells with fibrous septa and lymphocytes. Classic dysgerminoma appearance. Don't mix it up with the yolk sac tumor or granulosa cell tumors.
Love it. Malignant but totally beatable if caught early. Definitely one of the more manageable ones.
All right, Reem. Next one. A 6-year-old girl comes in with rapid abdominal distension and pelvic pain. Imaging reveals a large ovarian mass, and her serum AFP levels are sky high. Histology shows Schiller-Duval bodies.
Haram. Poor kid. I think I might know what this is. This is a yolk sac tumor, right?
Exactly. Also known as an endodermal sinus tumor. It's the most common malignant germ cell tumor in children.
Okay, and those Schiller-Duval bodies, you said that's a classic finding?
Yep, they look like glomeruli, a central blood vessel surrounded by tumor cells and a space, kind of like a mini kidney. You'll also see AFP positive hyaline droplets in the cytoplasm.
And prognosis?
Bad if untreated, but with combo chemotherapy, survival has improved dramatically.
That was a short case. Now let's go for a quiz. What histologic structure is pathognomic for yolk sac tumors? A. Hobnail cells. B. Call-Exner bodies. C. Renke crystals. Or D. Schiller-Duval bodies.
And the answer is B. Call-Exner bodies.
Actually, no. It's D. Schiller-Duval bodies. If you see them, think yolk sac tumor. Don't forget the AFB either.
Thank you for correcting me. Now, here's a rare and aggressive one. A 19-year-old woman presents with pelvic pain, a large ovarian mass, and a very high beta HCG levels. Biopsy shows cytotrophoblasts and syncytiotrophoblasts, but no chorionic villi.
Yikes. So this is choriocarcinoma, but of non-gestational origin?
Exactly. Unlike gestational choriocarcinoma from the placenta, this is a germ cell tumor, and it's even more aggressive.
And it spreads hematogenously, right?
Correct, especially to the lungs, liver, and brain. It's notorious for early bloodborne metastasis. Histology shows a biphasic pattern of syncytiotrophoblasts and cytotrophoblasts, but you'll never see villi. That's how you'll distinguish it.
And how does it respond to chemo?
Not great. Non-gestational choriocarcinoma has a poorer response than its placental cousin, and the prognosis is generally worse.
Here's a practice question. In ovarian choriocarcinoma, which of the following features helps distinguish it from gestational types? A. Presence of cytotrophoblasts. B. Elevated beta HCG. C. Lack of chorionic villi. D. Biphasic trophoblastic pattern. Or E. Hematogenic spread.
The key feature here is C. Lack of chorionic villi. That's what confirms if it's non-gestational. All right, Reem. This next case has some very telling signs. A 30-year-old woman presents with amenorrhea, deepening of the voice, acne, and clitoromegaly. Imaging reveals a solid unilateral ovarian mass.
Okay, wait. Amenorrhea, virilization, and a solid ovarian mass? That sounds like an androgen producing tumor. I'm thinking Sertoli-Leydig cell tumor.
Exactly, also called androblastoma. This tumor is made up of Sertoli cells, which form tubules, and Leydig cells, which produce androgens.
So that explains the masculinizing features, like voice deepening and hirsutism?
Yep, and these tumors are typically found in young women, usually in their 20s to 30s. They're unilateral, and most of them are low grade and benign.
Do they have any unique histologic markers?
Definitely. You'll see tubules lined by Sertoli cells and eosinophilic stroma containing Leydig cells, which may have rinky crystals, although those are rare.
And are there any special variants?
Some Sertoli-Leydig tumors can contain heterologous elements, like cartilage or glands. These are usually associated with higher grade and more aggressive behavior.
But in general, prognosis is good?
Very good. Most are treated with surgical resection, and because they're usually unilateral, fertility can often be preserved.
Quiz time! Which histologic feature is most suggestive of a Sertoli-Leydig cell tumor? A. Schiller-Duvall bodies. B. Kahl-Exner bodies. C. Tubules and Rinke crystals. D. Hobnail cells. Or E. Signet ring cells.
And the answer is C. Tubules and Rinke crystals. Tubules would be Sertoli, and Rinke crystals would be for Leydig. It's a classic duo.
And when you see virilization, keep this one at the top of your differential.
Okay, Reem, I've got another case for you. A 58-year-old postmenopausal woman presents with abnormal uterine bleeding. On exam, she has a palpable adnexal mass. Endometrial biopsy shows hyperplasia, and her inhibin levels are elevated.
All right, so bleeding, postmenopausal, endometrial hyperplasia plus a mass. I'm thinking granulosa cell tumor, a classic estrogen producing ovarian tumor.
Exactly, you got it. Granulosa-theca cell tumors are part of the sex Cord-Stromal group, and they're known for making estrogen. That hormonal activity is what causes symptoms like menorrhagia, postmenopausal bleeding, and even endometrial hyperplasia or carcinoma.
That makes sense. And you mentioned inhibin. Is that a tumor marker?
Yep, inhibin is secreted by granulosa cells and is often used as a serum marker to monitor recurrence. Also, a classic histological feature is the presence of Kahl-Exner bodies. Those are little eosinophilic fluid-filled spaces surrounded by coffee bean-shaped nuclei.
All right, the coffee bean nuclei. So cute for something so dangerous. Are these tumors usually benign?
Most are low-grade malignancies, but they can recur years, even decades later. So, long-term follow-up is a must. They're usually unilateral and yellow on gross exam because of all the lipid content from the theca cells.
And the theca cells, do they contribute to hormone production too?
They do. The theca component helps with estrogen synthesis, and together with granulosa cells, they mimic the normal follicle environment. That's why this tumor is sometimes called a functional tumor.
All right, let's close this case with a question. Which histologic feature is most characteristic of a granulosa cell tumor of the ovary? A. Schiller-Duvall bodies. B. Signet ring cells. C. Hobnail cells. D. Kahl-Exner bodies. Or E. Syncytiotrophoblasts.
And the answer for this one is D. Kahl-Exner bodies. If you see rosette-like structures with coffee bean nuclei, it's granulosa cell tumor, especially in a woman with bleeding and elevated inhibin.
Awesome. Another hormonal active tumor checked off of our list.
And now for the fibrous trio. Reem, a postmenopausal woman presents with abdominal distension and pleural effusion. Imaging shows a solid white ovarian mass. There's no malignancy, but the ascites and effusion resolve after removing the mass.
Wait, isn't that Meg syndrome? So we're talking about an ovarian fibroma here?
Exactly. Fibromas are benign stromal cells made of spindle-shaped fibroblasts. And when they're associated with ascites and pleural effusion, it's called Meg syndrome.
And what's the difference between a fibroma, thecoma, and fibrothecoma?
That's a great question. Fibroma are mostly fibroblasts. Thecoma are lipid-laden theca cells, and they may secrete estrogen. Fibrothecoma is a mix of both. Grossly, they're usually firm, white, and unilateral.
And if thecoma is producing estrogen, we could see things like endometrial hyperplasia?
Yes. So, if you see a hormonally active ovarian mass in a postmenopausal woman, keep thecomas in mind.
Okay, answer this for me. A solid white benign ovarian mass in a postmenopausal woman is found to be causing ascites and pleural effusion. What is the most likely diagnosis? A. Granulosa cell tumor. B. Serous cyst adenoma. C. Fibroma. D. Dysgerminoma. Or E. Endometrioid carcinoma.
The answer is C. Fibroma. Especially if you see Meg syndrome, always think solid, fibrous, and benign. Alright, Reem. Here's a case with a bit of a twist. A 46-year-old woman presents with abdominal fullness, weight loss, and imaging shows bilateral solid ovarian masses. Histology reveals mucin-filled signet ring cells.
Oh, that's Krukenberg, right? A metastatic mucinous tumor. Most likely from the stomach?
Exactly. Krukenberg tumor is a metastatic signet ring cell adenocarcinoma, usually from the stomach, specifically the diffuse type of gastric carcinoma.
And bilateral involvement is the big clue here, right?
Absolutely. Bilateral ovarian masses should immediately raise suspicion for metastasis, especially when you see those signet ring cells, with mucin pushing the nucleus to the periphery.
Are there any other primaries that can give you a Krukenberg-like picture?
Yep. So, though the stomach is most common, you can also get metastasis from the colon, appendix, and breast, especially lobular breast carcinoma. But the classic Krukenberg? That's gastric.
And how do these tumors usually reach the ovary?
Mostly through transcoelomic spread, meaning they travel across peritoneal surfaces or sometimes via lymphatics.
Okay, now let's talk about something a little more gelatinous. Pseudomyxoma peritonei.
Oh, yes, aka the jelly belly tumor. This condition is characterized by massive accumulation of mucinous ascites in the peritoneum. It can cause distension, adhesions, and even intestinal obstruction over time.
And what's the source of all that mucin? Is it always the ovary?
Actually, no. The appendix is usually the primary site. It's often a mucinous appendiceal tumor that spreads to the peritoneum and then implants on the ovary, especially the right one.
Ah, so if we see bilateral ovarian mucinous tumors and mucin all over the abdomen, the ovary might just be the victim, not the culprit.
Exactly. And that's why it's so important to distinguish between primary mucinous ovarian tumors and those that are metastatic, like in pseudomyxoma peritonei.
Okay, so Krukenberg is metastatic signet ring cells, and pseudomyxoma peritonei is jelly belly mucin, usually from the appendix, but ending up in the ovaries too. Alright, Areeba, we've covered a lot of ovarian terrain today. How about we wrap things up with a quick fire recap?
Rapid fire recap? Let's go. Starting with the basics. Functional cysts. Two types here. Follicular cysts form when the follicle fails to rupture. Luteal cysts form when the corpus luteum doesn't regress. Both are non-neoplastic and usually self-resolving.
Then we moved into the hormonal chaos that is PCOS, characterized by increased LH, insulin resistance, anovulation, and the classic string of pearls on ultrasound.
Then came the heavy hitters, surface epithelial tumors. Serous tumors are often bilateral and show samoma bodies on histology. Mucinous tumors are typically large and unilateral, but always make sure to rule out GI metastasis.
Then we talked about endometrioid tumors. They mimic endometrial glands and commonly have PTEN mutations.
And don't forget the clear cell carcinoma. It's aggressive, often linked to endometriosis, and has that clear cytoplasm with hobnail cells.
Then a quick stop at Brenner tumors, which contains transitional epithelium, kind of like bladder tissue and are usually benign.
Moving into germ cell tumors, we had quite the lineup. Mature teratomas are benign and filled with hair, teeth, and other bizarre tissues. Immature teratomas contain neuroepithelium. That's your red flag for malignancy. Dysgerminomas are made of clear cells, express c-KIT, and have an excellent prognosis. Now, yolk sac tumors show Schiller-Duval bodies and elevate AFP. Choriocarcinoma, the wild one, no villi, but super high beta HCG, and it spreads hematogenously.
Then came the sex cord-stromal tumors, the hormone producers.
Exactly. Granulosa-cell tumors secrete estrogen and show calyxner bodies. Sertoli-Leydig tumors produce androgens, may show Ranke crystals, and cause virilization. And fibromas are associated with Meg syndrome. That's the triad of a fibroma, ascites, and pleural effusion.
And finally, we ended with the metastatic tumors.
Right. Krukenberg tumors contain signet ring cells, are usually bilateral, and often originate from gastric adenocarcinoma. And pseudomyxoma peritonei, that's the one with gelatinous ascites, often due to a mucinous appendiceal tumor that spread to the ovaries.
Oof, that was a full ovarian workup. If this episode didn't make you love pathology, I don't know what will.
Seriously, shout out to the ovaries for keeping things weird and wonderful.
And that's a wrap on today's journey through ovarian tumors: functional, neoplastic, benign, malignant, hormonal, and even metastatic. Honestly, these ovaries are doing the most.
No kidding. From dermoid cysts with teeth to tumors that mimic the bladder, and even ones that show up uninvited from the stomach. There's never a dull moment in ovarian pathology.
If you enjoyed this episode, be sure to follow PodBites, leave us a rating, please be nice, and share it with your med school group chat or your favorite study buddy.
And don't forget, you can always revisit this episode when prepping for exams or reviewing tumors. Ovarian pathology may seem intimidating, but trust me, you've got this.
Thanks for tuning in. Until next time, stay curious, stay caffeinated, and as always, stay pathologically obsessed.
And if you're looking under the scope, you might also see hobnail cells.
Hobnail cells.
Hobnail cells.
We're finally talking about germ cell tumors. I know, no, this needs to be exciting. Okay, wait. There's an exclamation mark. Okay.
We're finally talking about germ cell tumors.
Let me tell you about them, girl. Okay. Oh no. Please let me say that. Or nor. Please. It's Australian. Australian, my. Or nor. Will you allow it?